Bismillahirrahmanirrahim. I'm grateful to PSH Organizing Committee, Professor Kashif Malik and Professor Altaf Alam for inviting and presenting at this prestigious meeting. It is actually very frustrating to be presenting in Lahore and not to be in Lahore, such a vibrant city. The topic assigned today to me is Hepatopulmonary Syndrome and Porto-pulmonary hypertension, diagnosis and management. And I will try my best to cover in the next 20 minutes some salient features and few learning practical points. It can essentially be described in a single sentence as a relation between two neighbors gone wrong. Liver cirrhosis, in true sense, is a multisystemic disorder and affects each and every organ of the body, and that makes it more lethal. And transplant is the only way forward. Today, we'll concentrate on lung involvement by these two syndromes. Hepatopulmonary syndrome, in fact, was first relation was noticed in 1984 when a lady with syphilis and cirrhosis became jaundiced, and the doctors looking after noticed that she had a respiratory compromise, and this led to the more physician looking for respiratory problems in cirrhotic patients. However, the term was first coined, Hepatopulmonary syndrome, by colleagues in North America in 1977, and few parameters have been defined to allocate the syndrome on the background of portal hypertension, a pulmonary disorder essentially by increased alveolar arterial oxygen difference of more than 15 millimeter of mercury. As we know, with age, your difference increases as well, hence above 64 years of age, it's deemed at more than 20 millimeter of mercury. For all practical purposes, on a blood gas, if your PaO2 is less than 70, which roughly corresponds to less than 95% on pulse oximeter, is useful for recognizing those with clinically significant hepatopulmonary syndrome. Its prevalence is around 15 to 20%, and it's important to recognize as this increases the mortality, frequency, and severity of complications of portal hypertension. Pathophysiology of hepatopulmonary syndrome is rather complex and multifactorial. In the lung with the normal alveolar unit, there's endothelial receptors A and B receptors associated with the nitrous oxide synthetase, which increases the nitric oxide level and leads to the dilatation of the alveoli. However, endothelial receptors A are vasoconstrictors, and they causes vasoconstriction. The rat model producing a cirrhosis by ligation of bile tubules. There was a sudden influx of chemokinins into the blood. Various factors like tumor growth factors, bile acids, etc. Inflammatory disorder is produced, and this is enhanced by bacterial translocation from the gut of endotoxins, tumor necrosis factors, etc. Along with this hyperdynamic state, there's a vascular shear stress. All these eventually leads to the increased endothelial toxin level 1, high levels in the blood. When this reaches the lung, endothelial increase, there's increase in endothelial ETTB receptors, which are represented by these green markers. Increase in these receptor leads to increased nitric oxide synthetase activity and nitric oxide levels, and eventually leads to vasodilatation and features consistent with hepatopulmonary syndrome. And essentially, in this diagram, a normal oxygen diffusion mechanism follows a very disciplined run of RBCs to a narrow pulmonary arteriole. In hepatopulmonary syndrome, the hallmark is dilatation of this pulmonary arteriole pulmonary vessel, resulting in diffusion-perfusion defect, and the oxygen is not well, blood is not well oxygenated, resulting in hypoxia. Hepatopulmonary syndrome these portal hypertension not essential is cirrhosis essential criteria is actually not, and hepatopulmonary syndrome can happen in chronic liver diseases as well as acute liver failure, non-cirrhotic portal hypertension, extrahepatic portal vein obstruction, chronic active hepatitis biliaris, and Budd-Chiari syndrome as well. So whom to suspect if you have a patient who has portal hypertension, which is a key for diagnosis, essentially means ascites, splenomegaly, pancytopenia, etc. and you on examination found them to have spider angiometas. There are studies which have proved that patients with increased spider angiometas have increased incidence of AV malformations and lung abnormalities, along with another sign of hyperdynamic circulation, which is clubbing and cyanosis. And such patient is complaining of shortness of breath and is requiring oxygen with no obvious cause, is essentially highly suggestive of Hepatopulmonary syndrome. There are two particular features and signs associated with this disorder, which is Platopnea and orthodoxia. Essentially, Platopnea is increased shortness of breath in while sitting up, and they feel better on lying down, which is opposite of left ventricular heart failure. And orthodoxia is essentially falling. If you're measuring their PO2 levels, there's a fall in about 5 millimeter of mercury or 5% from the baseline on sitting up. And if you have a patient, how would you investigate this? A simple test in your clinic is a pulse oximetry, which is cheap and readily available. If a patient of liver cirrhosis is there, if you measure their sats and they are more than 90% sitting up position, and they maintain it for a couple of minutes and walk around the room, doesn't make them short of breath, essentially, you don't need to worry. However, if they have dyspnea, low pulse oximetry, then you need to move forward and start with their basic tests, chest X-ray, pulmonary function test, CT chest. They are done to exclude secondary causes of respiratory diseases. In HPS, these pulmonary function tests are essentially normal, but there's a decreased carbon monoxide diffusion capacity. CT chest can show vertical inertia shadows. ABG is a paramount, which shows hypoxemia. And essentially, when you rule out cardiopulmonary disease, you can do a more specific and sensitive diagnostic type, which is a bubble echo or contrast echocardiogram, which I'll show you in the next slide. And when there's a delayed bubbles shunting, it is diagnostic of Hepatopulmonary syndrome. However, if they're intrinsic cardiopulmonary disease, you can still have HPS associated with pulmonary disorders, treat the disorders appropriately if the symptoms persist and there's still high suspicion of HPS. You can do a contrast echocardiogram, which if it doesn't give clues, you can do MMA, which is macro aggregated albumin scan. Radioactive albumin is infused. A normal person, all of it will stay in lung. However, if there's HPS, more than 7% of this albumin will be found in other organs such as brain, and there's diagnostic of HPS. If the MMA scan is more than 20%, it predicts a poor prognosis, and they will do worse with transplant. This is a bubble echo. Essentially, you take 10 ml of syringe, fill it with normal saline, agitate it, and infuse saline while doing echo. And this is right ventricular. You can see saline coming into the right ventricular, and after 3 to 5 beats, the bubbles are being infused on the left side of the heart, and that's is because the bubbles are not filtered by the normal vasculature of the lung because of dilated microvasculature. The bubbles make their way to the left ventricular and cause this peculiar feature. Severity classification is important because that essentially means the ones with the severe and very severe disease can get well description, and they are defined by the PO2 levels with mild, moderate, severe. The management of Hepatopulmonary syndrome is rather multidisciplinary based, and it should be done in the centers of excellence where respiratory, ICU, and transplant team is available. There is no effective medical treatment available for this syndrome. Various agents have been tried to help people, such as aspirin, indomethacin, methylene blue infusions, which inhibit nitroxide synthase and acetylcysteine. There's also been trials showing some efficacy of norfloxacin by decreasing endotoxemia and ET1 levels. And there are also some theories which suggest it inhibits nitroxide synthase, but effectively, there's medical therapy is not effective. What you can do is to give people long-term oxygen that makes them feel better, and this should be given if their PO2 level is less than 60, with aim of saturation around 80%. What it does is it improves their exercise tolerance and improves their quality of life, and increased oxygenations prevent hepatocytic damage and there's a decreased incidence of encephalopathy, hepatic encephalopathy in oxygenated patients as well. There's an interesting double-blind study from Florida which showed high dose of garlic for 6 months improved functional capability of these people as well. Garlic is cheap and available, and there's no harm in giving your patients. Also has cardioprotective effects as well. TIPS is contraindicated, and it's only experimental treatment. Settings of clinical trials should only be done. Liver transplant is the effective and the only treatment which can make a difference. In this study from Mayo Clinic by colleagues, elegantly show people with HPS and no transplant had a much more poor prognosis in 2-3 years' time rather than the ones who have transplant. And they also elegantly showed that baseline PO2 levels at the time of transplant predicts their prognosis as well. So people with HPS and PO2 levels more than 60 do better than the ones who have PO2 levels less than 50 and had a transplant. In the normal people who are waiting on transplanted, the oxygenation levels also decreases over the period of year. And once they have transplant, it takes about a year to completely reverse the effects of Hepatopulmonary syndrome and to boost their oxygenation levels as well. Health transplant is an effective therapy and should be considered early in these patients. This is one of the pictures I took while trekking to K2 base camp, and I couldn't resist mentioning that high altitude does have a vasoconstrictive effect on pulmonary vasculature, and there have been studies which have showed that incidence of HPS at high altitude centers are lower than the ones at sea level. Hence, you will see more HPS in Karachi rather than in Skardu. Coming to the second topic, porto-pulmonary hypertension, which sounds similar but is different from HPS, and has been defined by a clinical presence of portal hypertension. Means patients have ascites, splenomegaly, pancytopenia, features of decompensated cirrhosis, and you need to do right heart catheterization studies, which shows mean pulmonary artery pressure of more than 25 millimeters of mercury, with wedge pressure less than 15, and they have increased pulmonary vascular resistance. And this is diagnostic of portal-pulmonary hypertension. This is first coined in 1951 by Vance and Craig, and more evidence was found by the study from Los Angeles and states, where about 18,000 people who had autopsy found to have primary pulmonary hypertension in about 0.13% of cases. However, if they have cirrhosis on those autopsy specimen, the incidence of hypertension was increased to about 0.73% of cases. Prevalence of porto-pulmonary hypertension in context of chronic disease varies from 2 to 6%, and is rather a rare disorder. However, in 60 to 70% of cases, we found out that they have portal-pulmonary hypertension when they are evaluated from transplant, and in transplant evaluation centers, their incidence can go up to 8 to 10% as well. Pathophysiology of porto-pulmonary hypertension, again, is poorly understood, but essentially, as I tried to explain earlier, cirrhosis leads to increased ET1 or endothelial toxin level 1 in the circulation. This is compounded by portosystemic shunting. So essentially, the lot of portal blood is gone into inferior vena cava rather than being filtered by liver, and the pulmonary vasculature is exposed to high volume of blood. There's also leaky gut. There's bacterial translocation, endotoxemia. Increased level of serotonin has been implicated. Serotonin is a powerful vasoconstrictor and also causes damage, intimal damage to the smooth muscle wall, causing hyperplasia. They have also increased levels of thromboxane, decreased levels of nitric oxide and prostacyclin, which leads to vascular damage. And these all multifactorial, when combined together, causes systemic hypervascular state, but with peripheral vasodilation, but pulmonary vasoconstriction leading to pulmonary hypertension. And the end result of this process is from normal alveoli to well-defined capillaries. They get vasoconstriction in porto-pulmonary hypertension, and in contrast, in hepatopulmonary syndrome, this vasculature is dilated. Hence, there's a basic difference between these two conditions. The risk factors for portopulmonary hypertension has been well defined. Although the prevalence is equal in male and females, female are more prone to develop this condition. Autoimmune hepatitis is more associated with it. However, patients with Hep C infection are less likely to develop portopulmonary hypertension. There's not much well known about the natural history of portopulmonary hypertension. However, the revealed registry, which has about 3,000 cases in 55 centers across USA, and they observed their history for a couple of years, found out that the people with portopulmonary hypertension, the bottom two lines, blue and green, they did much worse than the top two lines, which are primary pulmonary hypertension, and their prognosis was worse as compared to primary pulmonary hypertension. And they also elegantly showed that the people who had portopulmonary hypertension with cirrhosis has worse prognosis than with the ones without cirrhosis. And this is the subdivision according to the severity of cirrhosis according to the child's classification. Portopulmonary hypertension has been graded into mild, moderate, and severe, depending on mean pulmonary artery pressures. Up to 25 to 35 is mild, and severe is more than 45. This is the severe group is where the transplant becomes controversial with very high mortality and morbidity, and as actually most of the centers will not take patients. So whom are the people you need to screen for this portopulmonary hypertension? It normally takes about 4 to 7 years before, after portal hypertension, before portopulmonary hypertension is diagnosed. Doppler echo is the screening test of choice. And whom to screen? Essentially, anyone with the chronic liver disease and portal hypertension with respiratory symptoms should be offered Doppler echo. The ones who are awaiting transplant, they should have assessment at the start. And then, however, it's well known that portopulmonary hypertension can develop quickly in 2 to 3 months. So those who are waiting on transplant list and present with shortness of breath should have Doppler echo done. And some centers advocate echo every 3 months while on transplant, which sometimes is not practical. So the diagnostic test for portopulmonary hypertension for screening is to Doppler echo, and if it shows right ventricular systolic pressure more than 50 as a group which picks up moderate to severe portopulmonary hypertension, they go ahead with right heart catheterization to confirm the diagnosis. The ones who have less than 50 can be reassessed in 12 months. And the ones, if the right ventricular pressure is less than 30, then that effectively rules out portopulmonary hypertension. The one between 30 to 50 can either be reassessed, or if they have bad liver disease, they should go ahead with right heart catheterization as well to measure to measure pressures if they have portopulmonary hypertension or not. Management of portopulmonary hypertension should be left to the experts in the centers of excellence with the respiratory ICU, hepatologists, and transplant physicians. However, for the colleagues who are looking after large number of patients in the community as well as in other centers, there are few rules which should we all know. The TIPS has no role, and it actually is harmful in these patients. So if they present with complications like bleed, please don't put TIPS in shunts in them. Calcium channel blockers are commonly used medications. Please actively look for those patients and stop those medications, and don't start them if they have portopulmonary hypertension, as they have no role. They can worsen portal hypertension. Beta blockers, while they are saviors in cirrhosis and chronic liver disease with good evidence, however, they deteriorate pulmonary hypertension by negative inotrope and chronotropic effect. Hence, they should be withdrawn and stopped, which improves their pulmonary dynamics and exercise capacity. Traditionally, pulmonary hypertension is being treated by anticoagulation. However, in this context of portopulmonary hypertension, anticoagulation has no role, rather make their prone to GI bleeds. The medical therapy is, in general terms, you can give them diuretics such as furosemide and spironolactone, but monitor them for decreased cardio output, renal failure, hypertension. Oxygen therapy is paramount to improve their psychological well-being as well as physical well-being. Pulmonary hypertension specific therapies have been developed over a period of year, and in UK registry of portopulmonary hypertension patients, the most common 65 to 70% of cases were used phosphodiesterase 5 inhibitors such as sildenafil and tadalafil. They are widely available, cost-effective, and an oral route. However, they can precipitate variceal bleed. They are effective in first 3 months, but slowly effectivity goes down. Prostacyclin analogs have been used as the next most common drug in 10 to 15% of cases. They are complex. They require IV infusion, monitoring, central line. However, more likely, an oral preparation is also available, but cost is an issue. Endothelial receptor antagonists have been a well-established therapy in pulmonary hypertension, such as bosentan, but they can make liver worse, so monitor them for liver toxicity. And most recently, guanylate cyclase increases nitric oxide levels, but the cost of 30 days therapy is hundreds and thousands of dollars. However, these therapies are effective, but the more effective therapy is liver transplant. In transplant, hospital mortality in these cases is very high, hence you have to be very careful, and comprehensive work is needed. The interest of time, I will move quickly, but low-risk patients to go ahead with usual transplant. Moderate-risk patients, depending on pulmonary artery pressures, need vasodilator therapy, and then optimized reevaluation in transplant. High-risk group is contraindicated for liver transplant, and this has been elegantly showed that people who had orthotopic liver transplant with both medical therapy and liver transplant do much better than the individual therapies alone. So if, Mr. President, if I can conclude the session, Hepatopulmonary syndrome and portopulmonary hypertension are two distinct, different entities. Their pathophysiology is complex and multifactorial. Portal hypertension, rather than the liver failure, predisposes to these issues. Hepatopulmonary syndrome, there's no effective medical therapy. It increases mortality 2 to 3-fold. Liver transplant is effective, and mild exception is available for severe hypoxemia. In portopulmonary hypertension, right heart catheterization is essential to confirm the diagnosis. Medical therapy is effective but expensive. It improves functional and hemodynamic outcomes and bridges patients to liver transplant. Liver transplant has higher mortality and needs comprehensive assessment and careful assessment. Excellent outcomes are reported for patients who respond to medical therapy and have successful liver transplant. Mild to moderate portopulmonary hypertension may reverse after transplant, but it can take up to a year. Hence, it's important that these patients are still continuously evaluated to need for their vasodilator therapy by experts. Thank you very much for your patience in listening, and I hope you enjoy the rest of your conference. Thank you.